32-year-old male, and he presented to the emergency department with complaints of profuse bleeding from his left groin for the last 4 hours. That was noticed by his wife and was brought to the ED. So the ED team on evaluation, when they informed us, they told us that there was blood spurting out from the groin. So they immediately packed the wound and applied compressive bandaging. And so when we went to attend to the case, the first thing that I saw was this patient was attached to the monitor, and he was tachycardic, he was hypotensive, but rest of the vitals were normal. I tried to talk to the patient, but I thought in my initial assessment that he was. I thought I was under the impression that this patient was under influence at the time. He didn't respond to me, so I gathered very quick history from his wife, and the first thing that I got to know was he had been bleeding like this, likely from the morning, from at least 3 a.m. in the morning when his wife first saw him. So in view of potential massive blood loss and present hemodynamic compromise, our initial aim at that point of time was to resuscitate this patient, do a quick ABCDE assessment, and also draw bloods for checking hemoglobin, to check his blood group, and to send for cross matching. So we were in the ER, and we were uh, uh, once the patient was a little bit more stable, once we gave him some fluids and the BP started to normalize, I took a more detailed history to try to find out what might have caused the bleeding in this patient. And then I got to know from his wife that this person was an intravenous uh, drug user. He used to take injection morphine, Phenargon, diazepam, tramadol, among many other medications, but most commonly these medications. And he had been taking these medications for the last 6 years. And like expected, IV drug users don't have a lot of good gains. And so he had been starting to prick his groin for we don't know how long, for easy vascular access. And by this time, this patient was stable enough that he was able to give us a history by himself. And so he told me that his last IV drug use was the night before presentation. And probably he took the medication and he went to sleep, and he was under influence and didn't know that he was bleeding. And when his wife woke up in the morning besides him and saw that he was profusely bleeding, she brought him to the hospital. And he also told me for the last 1 week or so, he had this pulsatile swelling in his left groin, which actually made it easier for him to inject, because it's not an easy task to try to locate the femoral vein for injection, especially when you have been injecting yourself for so long and your veins are not so good. And so this pulsatile swelling actually had made it easier for him to prick. So he was using that swelling in his groin to prick. And his wife told me that he had a similar episode of bleeding 3 days prior as well. But fortunately, it didn't last too long. It subsided on its own. But this time, it didn't seem to stop. So they brought him to our center. So on quick examination, I could see that his peripheries were cold, probably owing to so much of acute blood loss and also because of our fluids. In his right leg, his femoral and popliteal pulses were palpable, but ATA, PTA, and dorsalis pedis pulses were not palpable in both of the legs. Uh, I was not eager to remove the dressing because I didn't know from where this patient was bleeding, or if I could be able to immediately take control of the bleeding uh, at the ER, and also because he was not hemodynamically stable and we didn't know how much blood he had already lost. So we didn't want to poke around the wound at first presentation, but what we did was we did a quick bedside ultrasound, and we saw that uh, his arteries were not really good in both of the legs. In both femoral in right femoral artery showed only a biphasic pulse, and monophasic pulse throughout the rest of the arteries. So immediately, what challenge we faced was the first challenge was to try to secure an IV line for fluid resuscitation or for potential blood transfusion. But thankfully, we were able to secure two large IV lines in the brachial vein. So, but that was definitely a challenge. A lot of people had to try. We were planning to open a central line, but thankfully we were able to secure a peripheral line. Another thing, like I said, was we were not very eager to immediately open the wound on first presentation. We first wanted to stabilize the patient and then worry about why he was bleeding. But this was because he was not actively bleeding. Like when after the ER team applied gauze and compression, there was no visible soakage of the dressing. Had he been actively bleeding, despite those measures, we would probably have shifted him to the OT more faster and try to take control of the bleeding. But thankfully, he was not actively bleeding because of compression. So we just let it be. We the labs also they came back quite fast, quickly. We asked the people in the labs to run these tests fast, and what we found was the total counts were raised. Electrolytes and RFU was normal, but his hemoglobin was 6.4. So because of his hemoglobin, we decided to give him 2 pints of blood. So his vitals also improved, and his hemoglobin probably must have been improved. We didn't wait to check the hemoglobin levels, but we were expecting it to be around 8, so that at least we were comfortable that even if he had blood loss during the operation, which he likely would have required, um, we would be more comfortable with that. And then we decided we should examine the wound, because the wound had not bled and it had been around 2 hours in the ER. So we decided to have a look at the wound, and this was what we saw. So I'm not
What's
sure
really
how visible it is in the video, but this swelling, this infected ulcerated skin in the left groin, it's pulsating, and so we
also very
immediately
possible
realized that this was some sort of an aneurysm of likely the femoral artery, based on where the location is, just beneath the
possible right?
inguinal ligament. We also did a quick vascular ultrasound, and what we saw was this right here was the femoral artery, common femoral artery,
Also very possible
and there was an aneurysmal dilatation of the common femoral artery. And why this artery and this aneurysm, this pseudoaneurysm was not bleeding, was because of this clot that was preventing it from bleeding. So we quickly realized that this was actually a ticking time bomb. So we decided to shift him to the OT immediately.
possible
And
right?
so we shifted him to the OR while receiving second pint of blood. Under GA, we made an incision in the left groin, and we accessed the left common femoral artery. We saw the aneurysm. It was about in the proximal to mid region of the common femoral artery. We took proximal and distal control before uh, poking around in the artery, and also took control of the profunda. The aneurysm was clamped and it was buttressed, and then after buttressing it, we removed the clamps and we confirmed that hemostasis was maintained. After which we closed the wound. In the immediate post-operative period, both his limbs were warm. His pulses, like in the pre-operative uh, examination, and also in his right leg, his his anterior and posterior tibial pulses were not uh, palpable, but Doppler evaluation and ultrasound evaluation showed flow into the anterior and posterior tibial arteries, but popliteal pulses were palpable in both the legs. There was no soakage from the one side. He received one more pint of blood uh, after the OT, but he started ambulating from the first post-operative day. Our physiotherapy team also worked with him, and he was discharged by the fourth post-operative day. But the reason was we had planned to discharge him by third post-operative day, but because of some financial problems, he went one day later than intended. And this patient has come to us three times for follow-up. And last follow-up was 3 days ago. And so he comes from a very deprived, economically, financially deprived background. So he's working as a laborer right now. And what he told me was he experienced some claudication while working, while lifting heavy bricks on his back. And so that was one problem for him. Another problem was, unfortunately, he has started to take oral drugs again. Um, that was the reason we feared that he might inject himself. So that was why we didn't discharge him on anticoagulants. Unfortunately, he has already started taking oral drugs again. But thankfully he has not injected himself yet. But anyways, the limbs were warm on his last follow-up, and again his popliteal pulses were palpable. So that is how he is doing right now.
Thank you, Dr. Manjib. So,
Yes.
yes.
So yeah, so many. Just one thing. I think in between I lost track. So you were talking of the vein. He was looking for the vein, so he definitely had used his artery as injection area, right?
Right,
Not the vein.
not the vein,
And
right.
and the second thing is, I think in the course of the slides there was you said that there were no pulses in the popliteal and the popliteal artery and over the over the crural arteries, right?
Right.
Yeah. So so why would we expect him to after the operation have pulses? I mean, he didn't have pulses beforehand. Why should he have pulses afterwards?
Right. So I think because of acute blood loss and also because of hypothermia, I think that assessment, pre-operative assessment, was a little bit uh, misguided or biased.
Okay.
So there's no logical reason why he should have an improved pulse after the operation, because all we did was just ligate the aneurysm, didn't do anything with the artery. So yes, that's true. I think that was my assessment during in the ER, but I think that was skewed because of other factors.
Mm. Well, I think well, as far as I get it, you did everything right, and maybe just one point. If you see such a patient, I think you did actually, but maybe to stress that again, this ulcer is just is the whole diagnosis plus the history. So this patient, you know the problem right ahead when you see this ulcer. So that he used this as his injection area, and this patient is, of course, I mean, as you rightly diagnose, he's at high danger of losing really blood. So he definitely needs to go into the OR as quickly as possible. You did all the assessment. I think everything was done correctly, as far as I understand. Maybe I would have performed a quick CT, maybe, but that's just. It's not mandatory. What would you say, Dean?
Sure. I think that person is not having pulse at the time of examination is because of
I think that tightly applied bandage on the just over the femoral artery and that lesion. I think that bandage decreased the pulsation on the peripheral part. I think.
No, don't think so.
So, troubles with IV access. You guys are experts at cannulating varicose veins. So grab an ultrasound, just look for the vein and stick an IV catheter in it. So, don't forget, just, that's one way of getting IV access. You guys are good at that. Then I guess my question is the common femoral artery, that's what was damaged. Is the common femoral artery infected? Was the wall infected, or is this a ruptured false aneurysm?
Dr. Dean, this is like a ruptured pseudoaneurysm. No features of infection. We do had other cases where there were features of infection, but in this case, there was no features of infection.
Right. I mean, that's kind of the way it looked. It looked like it was a ruptured false aneurysm. And that's how you got it. You probably just had to put a simple stitch in the artery, right?
Yeah.
All right.
But it's a good question. Sorry.
And kind of going into it, you kind of need to think, hopefully you prep the whole leg, right? You prep the whole leg all the way down to the foot and the groin and so on. Because you got to think, well, if the anterior wall or if the artery itself is infected, you may have to resect it and use vein to fix it. So I'm just making you think downstream with what you find at the operation.
Yes. Yeah. Any comments by Satish?
Yeah, and this I think Dr. Mandip will present the next case also. Compared to next case, this case was a little bit easier as there was a obvious pseudoaneurysm that we were able to see in the intra-op findings, and there was, as Dr. Dean said, there were few stitches only required to close that nick of the aneurysm, and the patient flow on the femoral artery was very good post-surgery also. That was the reason I think the patient was doing good. But we were also always concerned about whether this patient will take the IV drug again or not. So my one question is like, for example, if a patient with the IV drug user and we do not know whether this patient will take IV drugs or not, in Kathmandu, in Manmohan Cardiothoracic Center, Vascular Center, they always used to ligate this kind of artery. So whether to ligate or to repair, that's always in our mind to repair or ligate. So do you have any experience or suggestion that whether we should ligate if such kind of patient comes and if it is infected, or repair it or something like that? Dr. D and Dr. Florian?
There's a clear answer to that, Satish. If everything is clean and it's no big deal, then try to fix it. Otherwise, you ligate the superficial artery, but not proximal of the junction, because that usually leads to loss of tissue, or maybe even to amputation. We had such cases in Berlin where there was a big drug abusing community, and so this is why I saw actually several of those cases. And unless it's not really infected, try to fix it somehow. Use a vein patch, as Dean said. Unless there's this situation when everything is kind of dissolved, sometimes in a very few cases, because of the infection and the re-injections, and the whole wall just falls apart. That can also be the case. Then you just have to ligate it to save this patient, but he will very probably lose his leg also.
Yep.
Yeah.
I think Dr. Mandip will present the similar case, next case. I think that was the case that we ligated the artery.
Yeah. So I would like to request Dr. Mandip to kindly present the last case. You can be a little bit fast with the history.
Right. So I'll just let you know the similarities and dissimilarities in this case. So this was a 28-year-old, again an IV drug user for the last 2 years, and he had also been diagnosed with DVT with inconsistent use of anticoagulants for the last 2 years. He was referred to us from Sheer Memorial Hospital with injection meropenem and clindamycin and enoxaparin and dabigatran for his DVT. Uh, on presentation, we saw a similar looking, but this time infected wound in his groin with a continuous serosanguinous discharge. So, on first thought, we thought that he might have pricked a lymph node from where all of this ooze might be coming. His labs showed that he had a raised total count, a CRP of more than 150, and a hemoglobin of 8.6. And this patient was having continuous fever despite being under meropenem and clindamycin. So we did an ultrasound, a quick ultrasound, and we saw again an aneurysmal dilation at common femoral artery, but this was not so easy for us to get. I think the reason is in the CT scan we can see that the aneurysm is located posteriorly and not anteriorly. So this was another difference that we had between the two cases. So again, we try to optimize this patient by giving him bloods, try to decrease the fever, try to increase the hemoglobin levels before we took him to the OR. But this was the picture that we saw in the OR, and this is another difference that we found, difference between the first and the second case, is that this guy had so much pus in his groin that the pus was, the psoas muscle was also discharging pus. And while washing the wound, we almost reached up to the acetabular joint, and still there was so much of pus. And so so that's the aneurysm right there in aesthetics. And we took external iliac artery control, washed the wound, and like Dr. Florian just said, we were worried that trying to save this artery would put him in more danger. Like the venous graft would not uptake, or even the synthetic grafts would not survive. So we ligated the femoral artery, and that is what is being seen in the video right now. But the good thing about this patient is still admitted with us, and post-operatively, his right leg is slightly cooled, but his capillary refill time is less than 2 seconds in both the legs. Saturation is more than 96% in room air, and it shows a normal pulse waveform. Uh, we were able to identify the culprit. As expected, it was Staph aureus, and the good thing is it was sensitive to amoxicillin, so the patient we were able to downgrade the antibiotics. Now the patient does not have fever. We also put a drain. The problem now is he's having quite a lot of drain output every day, so we have not been able to remove the drain till now. And also he has a lot of soakage from the wound, requiring dressing multiple times in a day. But the good thing is, till now, he does not have any ischemia, any signs of ischemia developing in his leg. And today in rounds, Dr. Svecha also did a Doppler examination, and so this is what we heard. So in these two cases, what we learned was again, sometimes we have to ligate, sometimes we might be able to repair aneurysms of the femoral artery, but ligation alone is definitely going to cause some intermittent claudication and also increases the risk of this patient having to get an amputation later on. Again, like we just discussed, if it's a contaminated field, arterial reconstruction might not be possible, and more often than we would like, these patients have other concomitant problems as well, like DVT, for which they might be on blood thinners, but that could be that could lead to uncontrolled bleeding if the aneurysm ruptures and bleeds. Again, relapse is a problem, and other problems like anemia, infection, cellulitis, psychiatric comorbidities, and even the risk of withdrawal when the patient is admitted. Again, these are problems that we have to deal with while managing these cases.
Yeah, thank you, Dr. Mandip. So any comments, Dr. Jean, Dr. Florian?
Who's that? Okay. So it's a very interesting case actually, and thanks for the presentation, Mandip. So two interesting cases, and I mean, what we sometimes hope is that they have already kind of built up collaterals because of the long time usage of this artery that leads to maybe blockage of this artery, so that they have like collaterals that might keep the leg alive. But I think, as you rightly said, in the long term, he will have claudication and maybe even, well, still face the problem of amputation. But that's not the main problem for the situation. And so I think, yeah, you did the right thing. I was just wondering, so there was so much pus in there, plus it was contaminated, and you closed the wound. It's might be kind of risky actually. So I thought about, for example, putting vacuum in there.
Yeah, we did have a vacuum drain in that case.
You did?
Yeah.
No,
Yeah.
vacuum, a sponge, I meant. A sponge, I meant.
No.
Yeah. But just an idea. I mean, if it heals, it heals. But I mean, there was so much pus in there that I'm really amazed to see how the wound heals afterwards. And even, especially because there was Staph aureus in there. Well, but I mean,
yeah,
maybe it heals. But the wound is still pretty fresh, right? So when did you do the operation? When was that?
That picture is from today. The operation was about 8 days back.
8 days. Well, okay. But then an infection which would actually have shown already. I mean, like skin or wound infection. Okay, so for that, it looks pretty good. Amazing.
Dr. Dean, comments?
Right. So my thoughts, I would have closed the wound also. Well, so number one, ligating the aneurysm was exactly what you needed to do. I probably would have gone with the idea, closing the wound, and even going with the idea that the next day I would take them back and wash them out again. You know, and maybe operate on them a couple times to wash out that wound, maybe left it open, like Florian said, but now you got a problem. How are you going to manage what you got going on now? It's probably a lymph leak. And, you know, maybe have your plastic surgeon people get involved. You may even need a muscle flap to go in there. I don't know, but the wound's going to still be a problem. But like I say, a consideration could have been was you closed it up, which I would have done, because if it ruptures, I mean, it'll be out in a free space. But I would have gone back maybe 2 days later or 2 days later to wash and clean it all out. You know, repetitive washouts. And I see we have 2 minutes left.
Oh, okay.
Yeah.
Okay, different ways to roam, and I mean, you're the one who have to handle the problem. And after 8 days, as I say, I think it looks pretty good. The wound, it's oozing a bit. Yeah, I mean, now I actually would go on just wait, see and wait.
Yeah. So we'll update about these cases in future also, how these patients will do in
Yeah.
future.
Yeah, okay.
You
So-
don't have you don't have vacuum dressings, do you? Or you have them, but they're very, very expensive. Is that correct?
We have some makeshift vacuum dressings,
Oh,
not
okay.
the proper
Okay.
ones.
Okay. Okay. Get it. Yeah. Okay.
We tried making one years ago. And the thing is, though, you could put it on and hook it to wall suction, and we tried that, but the nurse never hooked it to the wall.
Yeah.
Yes,
So
we
that's
tried.
You can
Okay,
use
yeah.
like a nasogastric suction, and just suck on the darn thing, but got nurses to do it.
Dean, it will not work, and we only have 1 minute left. So closing remarks.
So yeah, I would like to request Dr. Sanjay for closing remarks for today.
Hurry up, Sanjay.
So 50
Yeah.
seconds. Yeah.
Thank you for the presentation to 3 good cases, and it's like today. It's like if you spend time with smart people, then ultimately you will be smart one day. So that's like that. So I just want to spend time with smart people. So these are smart people. So smart discussion, smart presentation, and then it's learning, always learning. Yeah. Thank you, everybody.
Nice. Yes, thank you.
Thank you.
If
Thank
you
you,
meant
Sanjay.
us, if you were talking about us, then thank you.
Yeah, I'm talking about you guys.
Okay. Well, thank you. It was good.
So thank you,
Yeah.
everyone.
Thank you.
Have a great
Bye-bye.
day.